Yep.
Yes.
Fantastic. Okay. So I'm going to present on the work that my group's been doing really over the last decade. Just some of my disclosures. My primary disclosure, though, is the fact that I'm a neurosurgeon. I'm a clinician scientist here at U of T, but much of the time I spend is in service of patients with brain cancers. And as a clinician, I'll start with this clinical story. So this is a prior patient of mine, a 41-year-old man, healthy, was at dinner with his wife when he had speech arrest, and that took him to the emergency room, which is what prompted his meeting with me. He had a CAT scan and then an MRI, which showed this large enhancing mass in the left hemisphere of the brain, and clinically made sense of his speech arrest. This is in the area of the brain that's critical for speech function. And in a 41-year-old, to see this was concerning. The imaging appearances are consistent with a malignancy. By MRI, this looks like something called a glioblastoma. This is the most common primary brain cancer that we see in adults. It's an infiltrative tumor. What I mean by that is that even though we can see here this large mass, the nature of this cancer is that by the time of discovery, there are cells that have extended well far beyond that mass into the normal brain. It's often the case that we find these in young, otherwise healthy people like this gentleman. The treatments that we have involve what I do, safe maximal surgical resection, followed by chemotherapy and radiation. And I look enviously at some of my colleagues who are surgical oncologists for patients with diseases throughout the body. I've got colleagues who can resect 2/3 of a patient's liver, and patients are fine. The difficulty with the brain is, as you guys all know, that it's an asymmetric organ in which there are areas where function depends on structural integrity. And so for us, always resection and our goals oncologically are limited by our need to protect the patient functionally. These are also tumors, and I'll show some of this data, that are composed of cells that have remarkable therapeutic resistance. And again, as a surgeon, by definition, what I'm doing for a patient may be beneficial to them clinically, but it's not curative. And in fact, if we look at survival in patients with glioblastoma, it's quite dismal. This is something called a Kaplan-Meier curve. On the y-axis here is the number of patients who are alive. Each one of these ticks is a patient. And on the x-axis, time. And you can see from the time of diagnosis that most of our patients succumb within 3 to 4 years of their diagnosis. And this is from a landmark trial where patients were given chemotherapy in addition to radiation therapy after surgery, and that led to an extension of overall survival. But even with this multimodality treatment, median survival for these patients is only about 15 months. And again, part of the reason for that is because this is an infiltrative tumor. This is what these cancers look like under the microscope. You can see they're very cellularly heterogeneous tumors. And interestingly, if you look at these cancers, nearly half of these cells are not actually cancer cells. They're inflammatory cells and other parts of the brain stroma. But they're by nature infiltrative. This is an area outside of the tumor mass. These are normal neurons you can see here. And interspersed within the white matter of the brain are these multiple cancer cells. So this gentleman, again, presented in March of 2013. He had an awake surgery that allowed me to remove the whole of this mass. He had standard treatment with surgery, chemotherapy with temozolomide and radiation therapy, and he did remarkably well. I continued to see this gentleman in follow-up, and 6 years later still, his MRI looked clean. He had gone back to work as a banker. His son actually worked in my lab. You begin in cases like this as a surgeon to start having these delusional thoughts. Maybe I cured this guy. Later that year, his MRI started showing just small changes, but for us worrisome that his tumor was recurring. He was placed back on temozolomide chemotherapy because of the initial effect that he had had. By the end of the year, this is what his scan looked like, and he had functionally declined tremendously as a result. He received a salvage therapy, but he succumbed in the next few months after this. So I'm going to show you a second case, just to speak about kind of what I'll talk with you about scientifically today. This is a 29-year-old patient. He saw a colleague of mine in the outpatient clinic in April of 2018. He has a disease called neurofibromatosis, a genetic disease in which patients have gene loss of the NF gene. And he had this small lesion on his MRI in 2018. He presented to our emergency room with leg weakness, which is when I met him. This is not even quite a year after he had this initial scan. And now you can see this large enhancing tumor. He came to surgery, just like the gentleman before, had a glioblastoma, underwent the same treatment as the gentleman in that first case. But by July of that year, so during chemotherapy, actually after his second cycle, he began to have some radiographic signs of tumor recurrence. And by October of that year, had frank recurrence. In fact, it looks like we hadn't done anything at all. So this sort of variation in treatment, actually, clinically, we see all the time. I showed you this curve from the clinical trial that really established our standard of care for patients with glioblastoma. But if we look more closely, what we see that about 10% of our patients live for 5 or more years, but about a third of our patients have progression during adjuvant therapy, so during chemotherapy and radiation. And really, it's that complexity that really has driven my scientific program. And really, my scientific work and what I'll speak with you today has really been driven by these 4 questions. How do we explain the divergence in clinical outcomes in patients with glioblastoma? In that second case I showed you, clearly, the treatments we used had no effect on the tumor. And how does resistance in glioblastoma arise? What's the cell population that's responsible for disease recurrence? That first gentleman had a clean MRI for almost 6 years. Does glioblastoma have driver mutations that we can target? And I'll go through all of these today. So the first work that I want to show really was driven by these 2 questions. How does resistance in glioblastoma arise? And what's the cell population responsible for disease recurrence? And this work was driven by Rohit Sachveda and Angie Celebra, 2 former postdocs and students in my lab. I'll show you what they did. So this is work that we were involved in many years ago, using kind of a backwards genetics approach to try to understand when these cancers actually arise. This is when we see patients, is at time 0, when they have a tumor that's quite large and is manifesting now clinically. But if we look at mutational burden in clones and subclones of these tumors and try to work backwards, using that approach, we suspect that the initial oncogenic events that actually give rise to glioblastoma formation probably occur 2 to 7 years before the tumor finally clinically manifests. And there's a slow process after an initial initiation event that includes loss of chromosome 10, mutation of the TERT promoter, a period during which there's subclonal diversification, and then finally clinical manifestation. And now when we treat these patients with surgery and chemoradiation, that clonal and subclonal diversity narrows. And then we see again a new diversification that occurs at recurrence. And this state right here, where we've really narrowed clonal diversity, in our thought, really approximated what's known as minimal residual disease. This is a term that's used predominantly in the leukemia literature to speak to the presence of residual cancer cells after curative therapy. And in leukemia, it's been determined that the presence of minimal residual disease after conventional therapy is a predictor of disease recurrence. And in fact, the recurrence is really genetically driven by this population of cells that survive. And that population is not necessarily reflective of dominant clonal populations in the initial cancer. Interestingly, in leukemia, there have been efforts to try to characterize this minimal residual disease state and actually use that to guide therapeutics, with the idea that this represents a state where the cancer is particularly vulnerable because of the lack of clonal diversity, and that there is still a chance for curative therapy at this point. So we asked, could minimal residual disease be a concept that's relevant as well to glioblastoma? And what Rohit did was create an MRD model in the lab. We can take tumors from the operating room and harvest these cells and grow them as cancer stem cells. And they form spheres very similar to what you see when you grow neural stem cells in vitro. These spheres can then be dissociated and transplanted into immunocompromised mice. And what you see if you follow these tumors is that they slowly develop. You can see some degree of dissemination into the spinal neuraxis. When we treat these these mice with chemotherapy and radiation, much as we treat our patients, you can see that signal disappears. Inevitably, though, they recur. And Rohit decided, let's look at the cancer cells that are still there at this time after treatment, where we don't see any radiographic evidence of residual cancer, but we know that that cancer is still there. And when we looked at these cells with the help of Roel Verhoek and our colleagues at the Jackson Laboratory, Roel's now at Yale, what we identified is that these cells that survive do not express EGFR, they express GFAP, they don't express the neural stem cell marker nestin, but interestingly, they express this marker ID1. And this is really what interested us. So ID1 is a helix loop helix regulator. Unlike most HLH factors, which are transcription factors, ID1 doesn't have a DNA binding site. Instead, ID1 functions by actually binding other transcription factors and preventing them from binding to promoters. ID1's been described, as its name might suggest, inhibitor of differentiation, as a factor that's critical for maintaining stem cell identity. And this has been found to be critical across multiple different, both embryonic and adult stem cells, including neural stem cells. So this very much interested us. And we looked to see if we could understand the role that ID1 might have in glioblastoma. The first thing we did was use CRISPR to knock out ID1 from our glioma cells. And interestingly, this was actually very hard to do. Nearly every glioblastoma stem cell in which we tried to knock out ID1 would no longer propagate. It drove them all into differentiation. And so we ended up having to do this in glioblastoma cell lines. They were the only things that could persevere after ID1 knockdown. But what we found in these glioma cell lines was that when we knocked down ID1, it resulted in a significant increase in tumor latency. And interestingly, when we examined the mice of these, the brains of these mice that died, we actually didn't find tumor cells. We simply found a large inflammatory response that accounted for their demise. We then asked, well, what cell population does this ID1 positive glioma cell represent? And for this, we used a tracer experiment. So we took mice in whom tumors had been formed via xenotransplantation. And these mice were treated with EDU. And as you know, EDU is a marker that's able to integrate into the DNA of dividing cells. It can be stained for at a time where it's integrated. And then interestingly, over time, as those cells divide further, the signal washes out. And we took two different approaches, one where we delivered a single injection of EDU, and another where we delivered EDU through drinking water over 7 days. And I'll show you these two populations here. The red is an ID1 negative population. The blue is an ID1 positive population. What we found was that when we delivered EDU over a single injection, nearly every ID1 negative cell incorporated that signal into their DNA. And that very quickly over time, that signal washed out. It told us, in other words, that the ID1 negative population was made up of cells that were rapidly cycling. Conversely, when we did the same and looked at the ID1 positive population, only about 15% of those cells labeled for EDU, and over time that stayed steady. And the same was the case even after we gave 7 days of EDU. And it led us to suspect that ID1 positive cells in these gliomas are slow cyclers. We then tried to understand what role these ID1 positive cells might be playing in the whole of the glioblastoma population. And you can see when we culture these cells, they really constitute a small subpopulation of the whole. But when we treated these cells with chemotherapy, the same agent that's used for treating human patients, we can see that there's a slow expansion of the ID1 positive population. And interestingly, I won't show these data, but it seems as if two things happen. One is that treating these cells with chemotherapy selects for the cells that are ID1 positive. They preferentially survive. But it also seems to direct these cells that are ID1 negative to express ID1. So this was very interesting. It seemed like these were slowly cycling cells. It seemed that ID1 was a critical driver for tumorigenesis, and so kind of met the idea of a cancer stem cell in glioblastoma. And then we asked whether or not it could be therapeutically interesting, or I should say, if it might be part of what actually proffers chemoresistance in these cells. So what we did here was essentially look at the effect of temozolomide on glioblastoma cells before and after knockout of ID1, and this was using SI and shRNAs. And what we found was that knocking down ID1 greatly increased the cytotoxicity of these cells when exposed to temozolomide. So this was, again, quite exciting. As you know, we don't really have a mechanism by which to knock down proteins or genes currently in the brain. It wasn't really a therapeutic option, but we came across this. So interestingly, ID1 is also known as a oncogene in osteosarcoma. And in the osteosarcoma literature, there have been individuals who've been trying to develop small molecules to inhibit ID1 with the idea of improving the efficacy of their therapeutics. One of these agents that we identified was pemazide, which is an antipsychotic agent, so one that actually crosses the blood-brain barrier. And what we found was that in the same way that knockdown of ID1 increased the cytotoxic effect of temozolomide in glioblastoma, we found the same for pemazide. So pemazide treatment led to inhibition of ID1 expression in our glioma cells, and that further improved the cytotoxic effect of temozolomide. We turned then to a mouse model to see whether or not we could find the same effect in vivo. And this is a flank model here that you're seeing. And we treated these mice with both temozolomide and pemazide. And you can see here in the mice that received concurrent treatment with pemazide, the effect of temozolomide on these tumors was dramatically changed. And we found the same in an organotypic model. So this was looking at tumors in the brain. And you can see that some cells survive dual treatment, but it's a remarkable change between the two. And we saw the same in terms of survival. So I'm going to move to a different topic now, which is how do we explain the divergence in clinical outcomes in patients with glioblastoma? And this is ongoing work being driven by one of my doctoral students, Marina Nikolopoulos, and being done in collaboration with Melanie Spears, Jan Bayani, and Bhatia Ken at OICR. And really what we've asked together is, can we predict response to therapy and clinical outcomes in patients with glioblastoma? And I'll put this slide up again, that about 10% of our patients survive 5 years, but about a third of our patients progress during treatment. And there have been multiple different attempts and efforts to genomically, transcriptomically describe the variants that we see in glioblastoma. We know it to be a heterogeneous disease. Interestingly, these efforts have given us different subgroups of glioblastoma, but none of them have been clinically predictive. And here, what we decided instead was to take a very biased approach. So we started with 3 very different biased groups based on clinical divergence of outcomes. So we identified a group of patients with very poor survival. These are patients who, like that second patient I showed you, have tumor progression during chemotherapy and radiation and succumb within less than a year from their disease. We found a second group of patients who essentially looked like patients in the clinical trial that I showed you. They have what we call standard response to therapy. They live for about 15.5 months. And then we found a third group of patients who have remarkably fecund response to therapy. And this group actually had a median survival of almost 4 years. We took tumor tissue from these patients and took them through multi-omic analysis. And interestingly, what we found is that on a transcriptional level, early progressors are absolutely distinct from long-term survivors. You can see multiple of these pathways are well known in the cancer literature and even in the glioblastoma literature, but they really distinguish these 2 clinical groups from each other. And excitingly, one of the real outliers that we found here was ID1, the same molecule that we had found in the approach that I described before. These tumors are also metabolically very distinct. And interestingly, early progressors show increases in glucose transportation, in arginine metabolism, and decreased epigenetic regulation compared to late progressors. So these really biologically look like distinct tumors. When we looked just at ID1 and looked at data from the Cancer Genome Atlas, interestingly, ID1 expresses negatively with PFS. So high ID1 expressors have much poorer progression-free survival than ID1 low expressors. Again, compatible with our functional data that I showed you before. ID1 is also predictive of overall survival. Again, high ID1 expressors have poor survival. We're working now to actually integrate these multi-omic data into some sort of predictive algorithm. And we're working closely with colleagues of ours who've created machine learning algorithms that allow us to integrate these multi-omic data. So we're processing the genomic data, the transcriptional data, the metabolomic data, and proteomic data, essentially to create a unified way of identifying risk groups in this disease. And what we've generated so far has allowed us to identify low risk, medium risk, and high risk groups. And we're working now with colleagues at UCSF and Northwestern to expand that data set and hopefully in an iterative way validate this further. Our final goal is to have something very similar to what our breast cancer treatment colleagues have in Oncotype, which allows from initial diagnosis to really predict who's going to have aggressive and less aggressive disease and tailor therapies accordingly. So finally, this last portion that I'll show you is a project that is ongoing now to try to see if glioblastoma has driver mutations that could be targetable. And this is work that I'm doing with Julie Bennett here at Sick Kids, Mary Jane Linfat, a neuro-oncologist at Sunnybrook, and Uri Taburi and Cynthia Hawkins, also at Sick Kids. So I'm going to return to this case. So this young man with neurofibromatosis had this small lesion visible on his MRI in April 2018. Less than a year later, he presented with this large tumor that was manifesting as leg weakness, underwent surgery. When we look at his risk score using our algorithm, he actually falls into a high-risk category. So by prediction, someone who would show progression during chemotherapy and radiation, and indeed, that's what was the case for him clinically. And again, he had near total tumor recurrence less than a year after his initial presentation and during treatment. So I'm going to step away from his case for a moment and just show you some work that we've been doing to try to identify targetable driver mutations in adolescent and young adult patients with recurrent glioma like him. So I should step back for a moment and tell you that the new World Health Organization guidelines identified two different groups of patients with glioma: patients who have adult type high-grade gliomas and patients who have pediatric type low-grade glioma or high-grade gliomas. And really, this is a molecular distinction that's been made based on epidemiologic differences that we see in oncogenic characteristics of these different cancers. In children, you can see these are very common driver mutations that we see. You can see these are mutations in histone, mutations in the isocitrate dehydrogenase gene, which really don't show up until patients are in their teens. And then these are patients who actually have mutations in the MAP kinase pathway. And you can say there's variability by age. These are epidemiologically more prevalent in childhood. But if you looked at the literature, you could see there were reports of these sorts of driver mutations being present in cancers in patients in their 20s, 30s, 40s, and even 50s. So it doesn't respect this distinction that we make between pediatric and adult tumors, even though they're more prevalent in younger people. So we decided to look at our own patients, and we looked at our AYA patients defined as age 15 to 39. And you can see these patients have a diffuse kind of cadre of different cancers that we see. Some actually benign tumors like pilocytic cancercytoma, others aggressive tumors like high-grade gliomas. We took these patients through a tiered testing approach, and this was really developed clinically with the idea of being something that would be a tool that garners us identification of mutational changes that could be targeted. And we did this in an iterative approach where tumors would be taken through this tier 1 testing, and you can see the kind of what's captured there. If we didn't find hits here, we would then take it through a DNA panel with targeted sequencing, what we call tier 2. And then finally, if we didn't find hits there, we would expose these tumors to methylation testing. And interestingly, what we found was that nearly 15% of these patients had tumors that harbored a targetable driver mutation. And the common mutations were in the RAS MAP kinase pathway, histone mutations, and then mutations in IDH. And all of these are ones that we now have targetable therapies for. And some of this varied by age, but you can see from this waterfall plot, again, many of these tumors had targetable mutations. And again, these are all ones for which we have druggable targets. There was age variation. We saw a different prevalence in our younger patients than we saw in our older patients. IDH mutation really peaks in the 20s to 30s. BRAF fusions are more common in our younger patients. But again, we saw these pediatric type tumors across the board, and we saw these adult type tumors even into younger age. And really, one of the things that was critical was that here the biology really drives tumor behavior. You can see these are all patients with either high-grade or low-grade glioma, but the progression-free and overall survival really are driven by the underlying biology. Patients with BRAF fusion, you can see, have almost 100% survival compared to patients who have TERT promoter mutations who do quite poorly. This is, I'm showing this because this is really what became critical for that second case that I showed you. One of the more common mutations that we saw was in the BRAF gene at the V600E position. This is an activating mutation. It's a mutation that's shared with some other cancers, including melanoma. And it was the prevalence of this mutation in melanoma that really led drug companies to do the work to develop druggable approaches to this mutation. And this is a mutation that's more common in children, but that we see as patients go into adulthood. So because we found about 15% of these patients have a targetable therapy, or targetable mutation, sorry, and our conventional therapies really are not particularly effective for these patients, we developed this consortium that we call Canon. We meet bi-weekly. Initially, we started simply by consolidating our different treatment teams here in Ontario, but now we are partnered with colleagues across Canada. We have about 140 providers who attend these rounds across 22 sites. It's multidisciplinary in nature. It includes pediatric and adult practitioners from neuro-oncology, from neurosurgery, from radiation oncology, from neuropathology, and we discuss cases every week. We've discussed about 400 cases so far. Again, for many of these patients, we end up deciding on targeted therapies for their treatment. This is what these rounds look like. They're the sort of thing that simply couldn't have existed before COVID. None of us liked to meet virtually, but these rounds work because virtual rounds are just our norm now. And we're actually starting as a consortium now to work towards integrating liquid biopsy into our approach for patient care. This is using both blood and CSF-based liquid biopsy, but we've created ethics umbrellas throughout Canada now, where all of these patients have CSF and blood collected. We're using that to find directed tumor markers that are specific to their tumors. These are all patients for whom we have pathologic analysis. And the goal really is to develop liquid biopsy here, both as a diagnostic and as a means for following efficacy of treatment. And finally, to identify tumor recurrence before our normal surrogates of radiographic recurrence arise. So I'll finish with this patient again. He returned to surgery after this recurrence. We studied his tumor. At this time, we found evidence of MAP kinase activation and upregulation of DNA transcription. He was placed, rather than back on salvage chemotherapy, on a MAP kinase inhibitor, dabrafenib, and on a DNA transcription inhibitor called VAL-083. And with these agents, this gentleman has had durable tumor control. This is a patient for whom our conventional therapies, frankly, were meaningless. So I showed you a lot. I'll conclude with this. We've identified ID1 as a master regulator of tumor resistance in glioblastoma. We're looking at developing small molecules now that would allow us to target ID1 as a way of overcoming therapeutic resistance. I hope I've shown you that glioblastoma is histologically a single disease, but biologically multiple different diseases. We're hoping that multi-omic profiling will allow us to develop algorithms to predict treatment response. Clinically, what this would mean is that we know that there are some patients who respond well to our conventional therapies. Those are the patients we would treat in that manner. We also know that about a third of our patients do not have any meaningful response to our conventional therapies, and we would hope to identify those patients and treat them through clinical trial. Nearly 8% of patients with glioblastoma and 15% of patients with gliomas overall harbor a targetable mutation. And for these patients, it may very well likely prove that the targetable approaches that we have, targeted therapy approaches we have, are actually much more effective than our conventional approaches for treating them. And really, this is an exciting and difficult time where we're trying to understand how to even develop clinical trials for these patients. The standard approach that we have with randomized control trials really won't work for thinking about how to incorporate precision medicine into these paradigms. So I'll finish there. I've been lucky to have remarkable colleagues and collaborators and receive funding to support our work. With that, Samantha, I'm happy to take any questions.
Thanks so much. That was great. Does anyone have any questions? You can unmute yourself or put it in the chat, whatever you prefer. Go ahead, Soren.
Yeah, thanks. That was really cool. So the survival of the BRAF mutant patients looked quite remarkable. So these were just treated with standard of care, not like vimorafenib or something like that, right?
Yeah, so Soren, this is a relatively new finding, frankly, that even these high-grade gliomas harbor BRAF mutations.
Mm-hmm.
I think we are much more comfortable thinking of this mutation being a driver in patients with low-grade glioma, where there's simply less clonal diversity and there aren't as many other associated mutations present. We have actually now good data that patients with low-grade glioma, where we find a BRAF driver mutation, those patients should receive targeted therapy, not chemotherapy. We have good data showing survival is better in those patients. It's less clear in patients with high-grade glioma. And I will say it's less commonly the case that we find that mutation. So part of the difficulty is, frankly, trying to understand how are we going to actually test this idea. It's fine to have these N of 1 findings, right? And there are quite a few of these N of 1 findings now published in the literature of cases like mine that I showed, where we've had patients with very durable response with MAP kinase inhibition. It'll be harder to study it systematically, frankly. It has changed our practice. So my neuro-oncology colleagues typically now, in these patients who have BRAF mutations, these are patients where they will treat still with chemotherapy and radiation with temozolomide, but they will be kept on a maintenance MAP kinase inhibitor for treatment after conventional therapy. I
That's
don't think
cool.
we've convinced anyone yet to consider it as a an upfront therapy for high-grade glioma.
Right. Yeah. That's a little more tricky, I would imagine. So I have a second question, unless anybody else does. How are you thinking about CSF versus plasma for
Yeah.
liquid biopsy
Yeah.
assays?
You know, it is part of the difficulty. There are multiple groups that have worked on this and shown, I think, very well that there is not a huge amount of ctDNA that's shed into the systemic circulation from these intracranial tumors, despite the fact that the blood-brain barrier is often compromised in the high-grade tumors. You just don't find a lot of ctDNA there. I collaborate with a group that has been using Raman spectroscopy from systemic blood, from blood, and in that level we have a very clean and reproducible signal. So it's certainly there. It's just probably at very low levels.
Yeah.
The levels in CSF are higher. Interestingly, if I drain a tumor cyst and we do ctDNA from that tumor cyst, it's not surprisingly even higher.
Yeah.
And so there have been groups that have talked about putting things like Ommaya reservoirs into the tumor resection cavity and using that as a way of looking at cell-free DNA. It's a variation from standard of care, so it's hard to say that's something we should do. But it's certainly a problem. One of my colleagues, Gallerizadeh, had a very nice paper looking at methylation profiling from systemic sources. And again, they had a relatively good reproducible signal. And I think it probably speaks again to the same work that we've published on Raman spectroscopy, that it's there, it's just at very low levels.
Yeah, sure. Cool.
We have a question in the chat. Is the mutation in IDH developed later, or is it present at the time of birth and expressed later in life?
Yeah, this is also a great question. So almost uniformly, these patients do not have Ollie's disease. So Ollie's disease is a genetic disorder in which patients are born with an IDH mutation. I've had one patient who developed a glioma in that setting, but for most of these patients, it's a somatic mutation, not a genetic mutation. So it's not in the germline. We do think that IDH1 is the initial oncogenic event in these cancers. It's a clonal mutation that's found in all of the cancer cells in these patients. This is a great question. When does it arise, right? So this is really interesting. One of my colleagues, Peter Dirks, who's at Sick Kids and very active in this AYA work with me, he and Uri Tabori have developed this idea of cancer interception for glioma. So that same picture I showed you from that second patient of that small area of flare signal hyperintensity on the MRI, it's interesting, speaking with Peter, it's interesting how many times he would see patients like this in his clinic who were 6, 7, 8 years old. And he'd watch them, and maybe it would slowly grow over the course of a decade. But then they turn 18 and they graduate. And then I would see a 24-year-old who had a frank tumor. And we started connecting the dots. And interestingly, many times that 24-year-old I saw with that frank tumor was that 6-year-old that he saw with a tiny little dot. Now, we've only been able to work backwards so far. He and Uri now have started with this idea of cancer interception in mind to actually consider intervention in these 6, 7, 8-year-olds. And interestingly, there are IDH mutations there. So Peter will take these patients to surgery, we'll look at these small foci. They're not histologically anything that we would consider tumor, but there are IDH mutant cells. And again, in that same way that I showed that timeline of oncogenesis or glioblastoma, that we think that it may be as long as nearly a decade from the primary mutation to clinical manifestation of disease. You wonder if the same is the case in these IDH mutant low-grade gliomas, but there's just a much longer preclinical window.
Great. Are there any other questions? If not, I'd like to thank Dr. Sunit Das for a great talk, and everyone for joining today. Thanks so much.
Sam, thanks so much.